Hello and welcome to Dr. Journal Club. This is your host, Dr. Joshua Goldenberg. Today we're going to talk about a different type of study than we normally do. As of this recording, just came out a couple days ago in the Annals of Internal Medicine. And this is basically a study of using risk scores and trying to figure out which is the proper one to use. So let's talk a little bit about background. Basically, risk scores are incredibly helpful. I don't know about you guys, but we use them a lot in our clinic. Patient comes in and presents with, this type of blood pressure, this type of systolic. They're on hypertension meds. They're not on hypertension meds. They have a history of disease. They don't. They've got a high sensitive CRP that's off the charts or not. All these different biomarkers, all these different risk factors we throw them into algorithms to give us some predictive sense of whether or not these people will go on to have a heart attack, stroke, cardiac event, etc. over the next, 10 years or so, or over a lifetime. And we use this risk score to guide our therapy, or ideally to guide our conversation with patients about the therapy that they want to choose. Because of course, all therapeutic decisions are always going to be about weighing the pros and cons of therapy. And there's always cons, even if it's just cost and inconvenience. So basically, these risk scores are useful. And over, I guess since 98, there have been quite a few major risk scores that have been promoted to the entire medical community. Again, heart disease is one of the major diseases in American society and across the world, so it's probably the most important risk factor analysis that most primary care doctors will do. And five different scores have sort of been presented to us as a way of predicting risk and therefore informing your therapeutic decision making. And the assumption is that each year when the new one comes out, pretty much, especially recently, we assume that, okay, it's an improvement over the next one and an improvement over the next one. But there is a lot of limitations with risk scores. In particular, the main limitation comes from this, is that what we're basically using is data from patients from a different era, really, from many decades ago. And by definition, you have to do this, right? You have a whole cohort of people that presented with certain baseline risks, and they went through their life and they had a certain number of events. And based on those results, we sort of look back and say, okay, what were the factors that predicted this risk, right? 40 years later, 40, 50 years later. And now let's use this new tool, this new prediction tool on populations today. So, I mean, that's how else are you going to get a risk score, right? But inherent in that is that you're using risk derived from populations that are decades older than your current populations. And so we know we've all sorts of possibilities about why that could be a problem. One is just think about therapeutics. Therapeutics could become better and more powerful over the decades, right? So what might have been risky in the past is no longer so risky because it's well controlled by modern medications, etc. So there's all sorts of problems that we could have. So it's really important to get a sense of every once in a while we need to check in with our risk scores and say, hey, how do they actually perform in a modern world?